Hello everyone, and welcome to WePass's free webinar series. My name is Christina Ruiz, and I will be your moderator this evening. Periodically throughout the webinar, we will stop the presentation to review. There will be 5 poll questions that will appear on the left-hand side of the webinar window. Go ahead and answer these questions as they come up. You will have about 30 seconds to answer each question. Please feel free to use the chat window to ask questions or discuss the webinar. We will take time after the presentation to answer your questions posted. This and other recorded webinars will be available to WePass subscribers. Register through wepass.com to become a subscriber. Tonight's topic is Linac SRS, an end-to-end overview presented by Dr. Austin Frott, a senior medical physics resident at Duke University Medical Center in the Department of Radiation Oncology. Thank you for joining us, Austin.
Thanks, Christina. Can everybody hear me all right? I should have unmuted my microphone.
We can hear you.
Okay, good. So yeah, I'm going to take us through an end-to-end overview of Linac-based SRS. SRS is certainly a very broad subject, and we could certainly go on for a lot more than an hour. So what my goal here today is to kind of walk you through our treatment workflow here at Duke and to share some of our experiences and some of the things we do to kind of give you maybe an alternative perspective or review, maybe if you haven't covered SRS recently. So a couple of disclosures. I'm currently a resident. I have a couple months to go still, so I have not taken ABR Parts 2 or 3, and in this respect, I'm your peer. I did receive a small honorarium from WePass for giving this webinar. And my SRS experience is largely limited to the equipment at Duke University. So by mentioning or not mentioning a product or manufacturer, don't interpret that as an endorsement on my behalf or Duke's behalf. It's simply me just sharing that experience with you. So throughout the talk, I'll try and give you some relevant resources or things that you can review in preparation for the boards. And I guess it's appropriate to start with just a list of task group reports. So if you want to jot a few of these down, you certainly can feel free to. TG42 being the main one, as that's the SRS task group report. TG68 covers the stereotactic positioning system, so the head frames that we use for SRS. TG104 covers in-room KB imaging, so things like OBI or exact track systems. And of course, you have your quality assurance task group reports, TG142 and its precursor TG40. I threw TG66 on there for CT simulators. I'm sure if we dug deeper, we could come up with a number of other task group reports that might be somewhat related to the workflow itself. So I guess kind of launching into things, thinking of stereotactic radiosurgery, the root of that is stereotaxis. And the definition of that is the use of an external three-dimensional frame of reference to localize an internal point or region of interest. And it comes from the Greek words stereo and Latin taxis, so solid or a point, and taxis being arrangement. So stereotaxis as a concept is relatively old. I think the Horsley-Clark apparatus was developed for neurosurgery back in 1908, and that was an external frame that would fix to the patient's skull, and that was kind of our external frame of reference, and it would correlate to a brain atlas that would be used to determine the point internally that was of interest for neurosurgery. The first successful stereotactic surgery was in 1947. In 1951, Lars Lexell, who's shown there in the upper right and is kind of the father of stereotactic radiosurgery, came up with that concept at Uppsala University, and would later go on to develop the beam knife, which is what we now call a gamma knife at the Karolinska Institute, shown there at the bottom right. So that was kind of the start of SRS. Modern SRS maintains the same concepts with maybe some changes in implementation that's inevitable with advancements in technology. Some of the primary means of delivery are the gamma knife. That harkens back to Lars Lexell's beam knife. The cyber knife there in the bottom left, Linac-based SRS, which is what we'll be talking about today. I think there's even been some investigations with protons. I don't have a whole lot of experience with that, but it's something that's been looked at. And there's other specialty devices too. I think BrainLab has the Vero machine, and there may be other options besides those. But I think the three that I showed here are kind of the main implementations of SRS. SRS delivers ablative doses to the target with the goal of also minimizing normal tissue exposure. Primarily what we're treating is metastatic disease in the brain for SRS. There are a few non-metastatic diseases like trigeminal neuralgia, but by and large we're treating metastatic disease. I like to think of the Mets as just cancerous seeds. There's no healthy tissue in the actual target. So when we're delivering ablative doses that repair and normal tissue, the repair of normal tissue versus cancerous tissue is less important at these doses than standard fractionation. But what it also means is because we're delivering these ablative doses that we need to be extra careful to constrain those high doses to the target itself and minimize normal tissue. And we do that by delivering conformal doses with steep dose gradients. We need to be especially cautious if there are critical structures nearby. The brain itself is very important, so we want to minimize radiation dose to it. But there's also a few critical structures to keep in mind, such as the brainstem, the optic chiasm, optic nerves, maybe even the cochlea. We also need to be aware of how the target volume impacts the normal tissue that's irradiated. So I think a few of the hallmarks of SRS or the key points to take away when thinking of SRS are the accuracy of the treatment. We have very small associated margins. In order to achieve those, there are a few things that we need to do. We need to have a very accurate and robust immobilization system. Oftentimes we hold our machines to a higher performance. We have tighter tolerances for the QA, which QG142 covers briefly in terms of their tolerance for IMRT machines versus stereotactic machines. We're delivering very conformal doses. Also add with steep dose gradients. Those aren't necessarily the same, and we'll touch briefly on that. We're doing that to minimize normal tissue dose. And we're delivering very high doses in a single fraction. Some people will call 2 to 5 fraction treatments, or classified as SRT or stereotactic radiotherapy. A lot of the concepts for SRS will carry over to that, and I'll do my best to not use those words interchangeably, but we can think of a lot of the physics concerns similarly. So we'll start with our first review question, which there should be an option off to the left of your screen that looks something like a bar graph that you can click on to vote in a poll. The classical definition of stereotaxis is any radiation therapy procedure delivered with small margins, a means of localizing an internal point or region of interest from a rigid external frame of reference, radiation therapy treatments of 1 to 5 fractions, or any radiation therapy procedure using multiple imaging modalities in the planning process.
Please take a moment to answer the poll question posted on the left-hand side of this window. Once you have submitted your answer, you will be able to see how other participants have responded. We will review the answer in about 30 seconds. Thank you for answering the poll. Back to you, Austin.
Okay, good. It looks like we got a good response there. So the classical definition is it's a means of localizing internal point or region of interest from a rigid external frame of reference. And I think it's important to kind of appreciate that history to it. As we go towards more frameless mass, which we'll talk a little bit about in immobilization, it's become more of a hypofractionated image-guided radiotherapy, but we still associate it with SRS and using that external frame of reference. Okay, so the SRS workflow, now we'll kind of launch into going through some of the key steps in the process, starting with simulation or just general image acquisition. We do have an MR simulator in our department, so that includes both CT and MR images, but you can also have those images pushed from a diagnostic scanner outside of your department. Some of the concerns with fusion, contouring, both in terms of identifying what it is we're to treat, as well as some of the critical structures nearby. Those can impact our approach in planning itself. We'll kind of go over some planning strategies or some things that we take into consideration. All of our pre-treatment checks, So just keeping in mind chart checks, timeout procedures, things that we're doing to ensure that we're delivering this dose appropriately, and then the delivery of the actual treatment itself. And of course, we'll hit on associated QA with some of these tasks as well, because that's something that's very important to us as physicists. So mobilization is really the key to achieving the margins that we need for SRS. There's a few different options for masks and frames at simulation. TG68 breaks these down into minimally invasive masks, and those are kind of the pin and screw based frames that actually anchor into the patient's skull. Classically, that's what was used for SRS, and what we see a lot more of now are non-invasive frames, which are just mask-based frames made from a thermoplastic material that's formed to the patient's head. And I took a screen grab from BrainLab here in the bottom left, showing the two examples of these: the non-invasive as well as the fixed head frame, which is the minimally invasive. At Duke, we also use something called a U-frame, which I took a picture of and showed there in the bottom right. It is non-invasive in that it is using the thermoplastic material, but that is still anchored into that blue U-shaped frame and helps for a little more reproducible of an initial setup. So that's kind of a hybrid in the middle that I'll talk briefly about, and still uses the same localization techniques that the minimally invasive frames do. So the choice of frame is informed by the treatment to be delivered. For minimally invasive frames, we only use these for trigeminal neuralgia treatments. We deliver 80 gray to a point on the trigeminal nerve. Obviously, you never want to miss an SRS, but 80 gray is a non-trivial dose, certainly. So we want to be extra careful there. Minimally invasive frames sometimes afford a superior accuracy. It does require a neurosurgeon to be available. They'll help with placement and be available throughout the day. Placement, simulation, planning, and treatment are all done in one day, so this is a very resource-intensive procedure to place a minimally invasive frame and to treat with it. There's also non-invasive options. That's great for breaking the workflow up into multiple days or delivering multiple fractions if you take the approach of SRT. It's a little less resource-intense because you're breaking that up into multiple days. But you have to be especially careful to get a good fit. Check the points of inflection around the face and the head, the bridge of the nose. There's usually a mouthpiece that will go in to help prevent pitch of the patient head to keep that reproducible. And also checking around the base of the head and the back of the head. So realizing accurate treatments start at simulation and making those immobilization devices. I included a picture of our U-frame kit shown at the top, minus the thermoplastic material that's put on when the patient is there. We use a two-therapist team that sets the patient up and molds the mask. You need to be especially careful that the patient is still while the mask cools. We usually allow, I think it's about 15 minutes for the mask to cool. It can take a little while. You don't want to sim until that mask is rigid, because if you take your simulation images and the patient maybe moves afterwards before taking them out, then that reproducibility between your simulation setup and your treatment may be compromised. We'll have a physicist or dosimetrist come in to check the setup right before we take those images when the mask is formed, to check the fit, making sure there's no room for movement, that we can minimize that. Make sure that the localizer box base is flush with the cow base. So for some of the frame-based options, whether that be the actual minimally invasive or the U-frame, we'll put on this localizer box shown there at the bottom. You can see kind of metal bars running vertically there and diagonally. And those metal bars are ultimately what establish that external frame of reference that we can then correlate to the images. Now's the time to pay attention and speak up. It's a lot easier to make a new mask than to find out there is a compromised setup or something wrong with that on treatment day when you'd have to potentially restart the whole workflow over. We sim at 1 millimeter slices with a small field of view. Oftentimes we're looking at very small structures, so we want as good of resolution as we can reasonably achieve. And just QA the simulator itself per TG66 recommendations, with an emphasis on the spatial integrity of that QA, as well as image quality. MR imaging is actually used for the visualization of the volume to be treated, the GTV. We have our own departmental MR sim just down the hall from our CT simulator, so we'll take the patient there right after CT sim, Physicians usually have their own set of pulse sequences that the therapist can queue up and run. Some cases will have additional diagnostic images pushed to the treatment planning system, just similar to what you would just do if you didn't have a departmental MRI. You could get that either from wherever the patient had visited before, whether that was a different department or institution entirely. So things to think about as a radon physicist when it comes to departmental MR scanners. Spatial integrity is really key. You want to make sure that it's free of distortions, and those can ultimately come either from the scanner or from the patient. From the scanner, you may have inhomogeneities in the magnetic field or nonlinear gradients. Patient-related artifacts or distortions can come from susceptibility and chemical shift artifacts. The MR is going to be fused with the SIM. We're going to actually delineate the treatment volume with the MR, map it to the CT, and plan on the CT. So we need to be able to accurately correlate that GTV position in the MR over to the CT. Otherwise, we won't be treating the area we had identified. And so we'll QA our MR scanner with the ACR Phantom. And I took just a couple of key image slices there to the right. At the top, we know some of the dimensions of the Phantom itself and the cylinder in there that we can measure for our scaling. And then in the bottom right, we have a grid where we can check not only the size of those squares, but also to make sure that those lines are parallel and not warped at all. And so that's where we're checking for our distortion tests and ensuring that we have a high degree of spatial integrity. So a next review question. Which of the following would be indications for using a minimally invasive, and that's the kind with the pins or screws that fix into the patient's skull? The intended prescription is 5 gray times 5 to cerebellar met, and the patient must be reproducibly set up from fraction to fraction. A single fraction is to be delivered to treat the trigeminal nerve to 80 gray. A non-compliant patient cannot be trusted to remain still for fitting a thermoplastic mask, or D, all of the above. You should be able to go to the poll to vote on that.
Okay, so please take a moment to answer the poll question posted on the left-hand side of this window. Once you have submitted your answer, you will be able to see how other participants have responded. We will review the answer in about 30 seconds. Thank you for answering the poll. Back to you, Austin.
Yeah, I see that there's raised hands here. Is there a way that I can address that? I'm not sure if that means somebody has a question or...
I see that. You should be able to see the results of the poll. I see we have a question, and they would come up right after you answer the poll.
Yeah, okay. Okay, so it looks like the overwhelming majority said the answer is B, a single fraction will be delivered to treat the trigeminal nerve, which is correct. For a 5 gray by 5 treatment, you probably wouldn't want to place the mask each fraction. It'd be difficult to reproducibly do that, in addition to being uncomfortable for the patient to be continually trying to bolt that frame on. You certainly couldn't send a patient home with that frame still attached. If a non-compliant patient can't be trusted to remain still for a thermoplastic mask, you're probably not going to get any extra compliance from them by actually putting the fixed frame on. And so you might want to evaluate then how good of a candidate that is for something that requires the utmost accuracy. Okay, so once we acquire the images from the CT SIM and either have those MR images pushed from outside the department or departmental SIM, we'll fuse those with the CT prior to physician contouring. We do all of this in iPlan. We import everything and do contouring in iPlan, and we will do some plans there, and others we will push to eclipse planning. iPlan's autofuse works really well just because the skull itself is so rigid, so you don't have to worry about many deformations. When you go through and you check those fusions, you want to take extra care to evaluate the base of skull or base of brainstem lesions. As you get to the inferior portion of the skull, it can be a little less reproducible than the superior portion just because of inflection in the neck causing a bit of pitch. And you can constrain the region in which you do that autofuse, and if you include too much of the superior portion, because that's so easy to match, it will kind of bias that region, and so you'll want to be extra careful. And you want to evaluate the match as close as possible to the area of treatment and make sure that that's where you have that good registration. So typically in SRS, we're just looking to drive down the normal tissue dose as low as possible. We want a very steep dose gradient and a highly conformal dose distribution. There are some specific critical structures to be aware of in the event of maybe a challenging treatment volume location. So we contour those prior to the physician identifying the GTV. Those include the optic nerves, chiasm, the brainstem, the lens. If it's acoustic neuroma, we might do the cochlea or have the physician include that. And these can impact, or the impact on specific regions of the brain are evaluated by a neurosurgeon. So once we come up with the treatment plan, we will send a summary of that plan, including cross-sections of the isodose distributions to a neurosurgeon to review. And they can raise any concerns they may have if the, if the dose is near the motor strip or something like that. But they'll review all SRS and SRT plans prior to treatment. Typical prescriptions to targets. The prescription information being the dose per fraction or the number of fractions is a physician decision. As a guideline, RTOG 9005 gives maximum tolerable doses for a single fraction, and those were based on the size, the maximum diameter of the lesion itself. For lesions less than 20 millimeters, that was 24 gray, and while I call these maximum tolerable doses, for that one specific case, that was just the physicians didn't feel comfortable taking it to any higher doses, whereas maximum tolerable dose actually refers to clinical effects for 21 to 30 and 31 to 40 millimeter sized lesions, which are 18 and 15 gray in single fractions. For some larger volumes or lesions that may be close to the brainstem or in difficult areas, those are sometimes candidates to be broken up into 5 gray times 5 treatments for SRT. And the reason the volume informs that prescription so heavily is because if you were to have a fixed 1 millimeter expansion onto those volumes, that adds an increasing amount of normal tissue that will be treated. So we add that expansion to make sure that we're treating the GTV, but we also understand that there's going to be normal tissue irradiated as a result. And we can see here for varying diameter size lesions, that 1 millimeter expansion, I went and showed how much normal tissue is added as a result of that expansion, just to give you an idea of why that's something of concern. So once we've identified what to treat, in treatment planning there's a couple choices of collimation, and each kind of comes with its own pros and cons. Cone-based SRS, which I show a picture of there at the top with our cone and mount attached to our Novalis machine, increases the source diaphragm distance, so you'll get a little bit sharper penumbra, which can be beneficial. Makes it a little more difficult to treat irregularly shaped lesions. The MLC can be dynamically shaped to achieve more conformal doses. You may not have quite as good of a penumbra from the leaves themselves, but it's especially useful for irregularly shaped targets or the treating of multiple METs in a single isocenter or single fraction, which we've increasingly been doing. So as I said, the use of SRS has become increasingly common for multiple METs. There's a series of randomized clinical trials examining the effects of SRS with and without whole brain radiotherapy. There's a really good presentation that John Fibash and Evan Thomas of UAB gave that you can Google and look. And I pulled some information from their presentation, and they also have a few papers out regarding the treatment of multiple METs, particularly with a single isocenter. But kind of the summary of those studies was that the overall survival wasn't increased with the inclusion of whole brain radiotherapy, and these were looking at SRS treatments of 1 to 4 METs. but there was an associated risk of cognitive degradation from the whole brain. There was overall better quality of life without it. So as a result, we've gotten a lot more aggressive in terms of treating with just SRS for multiple METs, whereas in the past we might have just done whole brain radiotherapy. So the choice of isocenter in those cases can be dependent on the prescription or the number of METs or their location during treatment. If all lesions are a single fraction, that's easier to treat them with a single isocenter, but in some cases we might treat some of them with a single fraction and maybe a larger one or difficult one to handle with 5 gray by 5, in which case we'll have to do multiple plans and at that point consider doing multiple isocenters. Keep in mind what the separation between the lesions is and how the MLC width impacts that. We use variance HD MLC for our SRS treatments, and that has the 2.5 millimeter thick leaves in the central 8 centimeters of the field, and as you go outside of that, it's 5 millimeter leaf width. So if your isocenter, or if you have a lesion that's a ways away from that isocenter, you might be treating with those thicker leaves. As well as the farther away that is from the isocenter, your angular uncertainties can have a higher impact on coverage, as well as you need to start considering if you can make those appropriate corrections with something like a 6-degree freedom couch. Are there any lesions near areas with inherently difficult setups? The base of skull and brainstem, as I mentioned in the fusion slide, can be a difficult area. So if we have lesions there, we'll sometimes separate those out into a separate isocenter if we think we might have a difficult time getting that to line up. We'll create a single PTV with Boolean operators and iPlan once those targets are all identified by the physician. Then iPlan places the isocenter at the centroid. So the actual placement of that isocenter is not necessarily inside of a target itself, whereas if you had a single MET, single isocenter treatment, it is. And that's why I mentioned earlier that some of those angular uncertainties become especially important to consider. Collimator angle is also an important consideration in arc therapy. I guess I should have mentioned that we treat most all of our SRS cases with either VMAT or just dynamic conformal arc. And the collimator angle is important not just for single MET treatment, but also for multiple MET treatments. You want to avoid collimator angles of 0 and 90 degrees where the leakage will be parallel to the arc travel and can add up, or leakage caused from the actual leaf gap where the leaves abut. For multiple METs, you want to avoid gaps that can be caused by the leaf motion being parallel to the lesion separation, which is kind of a confusing way of saying it, so I included an image here to the right where you can see in the bottom one, those METs, in order to cover them both, the leaves will be pulled back and you'll increase dose to the normal tissue, which in this case is to the brainstem and the chiasm, especially important. Whereas if we were to rotate that collimator by 90 degrees, we can do a better job of still getting coverage without radiating some of that tissue in the middle. And even though you have an optimizer that's telling it to avoid those, it will be competing interests there for the bottom collimator orientation. Hotspots and conformality in SRS. Traditionally, SRS is prescribed to isodose levels less than 100% for non-modulated fields, so for dynamic arcs or for some of your cyberknife and gamma knife treatments. It's usually around 50% in gamma knife and 50 to 75% in Linac-based SRS. That's a little bit different for VMAT, but it's kind of similar to not constraining the maximum doses in the VMAT or IMRT plans. If you allow that hotspot to go up, you can oftentimes get much better conformality and steeper dose gradients, and thus reduce the normal tissue dose. Ian Paddock gives a good presentation on that and has done some work on different expressions of conformality and gamma indices. He does a good job of illustrating that, and I attempted to kind of show that to the right with a little cartoon, where the red line there is your prescription dose, and we have two different normalizations, the blue and the green curve. I hope that I can convince you those are the same shape. I just stretched them in PowerPoint to reflect different normalizations. And you can see on the green, as we normalize to a lower percent isodose line, we kind of have to stretch that up and it gets a little bit thinner. And the gaps between those two curves that the arrows are pointing to are basically normal tissue that's spared as a result of prescribing to, say, the 50% isodose line instead of the, the 90 or 95 or whatever have you. So plan evaluation, there's a few different metrics that we can use in SRS. Some of these carry over to non-SRS treatments as well, but we pay especially close attention to them. The conformality index is defined by ICRU 62 as just a prescription isodose volume over the treatment volume. Know how your TPS calculates this and the limitations to that particular calculation. If we're just looking at prescription isodose volume and PTV volume, if we see these two circles to the left, and this is kind of a theoretical treatment, if the prescription isodose doesn't overlap with a target but they're the same volume, that would be a conformality index of 1, which is clearly not the same as those perfectly overlapping and giving that conformality index of 1. And the bottom one is what we want, but with that top definition of conformality index, we would see it be 1 in both scenarios. Ian Paddock has the Paddock conformality index, which attempts to address this particular situation. The other thing we look at is the gradient index, which is the volume of 50% isodose divided by the volume of the 100% isodose. So the smaller that is, the steeper the dose gradient that we have. I think typically we're looking to keep that at about 3. A few other miscellaneous planning concerns or things to keep in mind. I'm personally an advocate for treating at the high dose rates. Some people are more conservative, and some people at Duke are more conservative than me. My thoughts are the less time the patient is on the table, the less time the patient can potentially move. We're delivering thousands of MUs because of the higher doses, and especially for the multiple MET treatments, that's going to increase modulation in the number of MUs. And so those treatments can take quite a while if you treat it at some of your standard dose rates. And options for upping the dose rate can be FFF mode, or we also have a Novalis Trilogy machine that has a 6X SRS energy that is stereotactic specific, and it's basically a truncated flattening filter that allows for treating at 1,000 dose rate instead of 600. But it's also important to know your machine and how good it is at modulating dose rate to avoid beam holds. Truvians are particularly good at this, as they have basically a supervisor that integrates the actual leaf motion and the beam delivery. Whereas normally, if the leaves make it outside of some tolerance, you need a beam hold for those leaves to catch up because they can't travel beyond their maximum speed. And as a result of those beam holds, you can run into dosimetry errors. Typically, though, we're delivering so much dose that it tends to be the gantry speed that is a limitation. But nonetheless, you know your machine before you get too aggressive with those dose rates. Be careful for gantry collisions with the frame itself. This is the U-frame mounted onto the couch here off to the right. And it kind of hangs below the couch a little bit. So if you have an anterior lesion that you have to drop the couch to treat, you may run into collision issues. A lot of times we're treating with non-coplanar beams where we have couch kicks, so you need to be careful of collisions there. For questionable cases, we'll always have the therapist perform a gantry clearance check. Again, that's something you don't want to find out on treatment day, that we have ample time to replan if necessary. Also be sure to use a high resolution dose grid. Use a 1 millimeter by 1 millimeter grid for all of our dose calculations. Okay, so another review question. For VMAT plans, collimator angle of 0 degrees should be avoided because large leaf gaps from multiple lesions increase normal tissue dose. The previous 2 answers have been B. Rotating the gantry along the leaf travel path can cause leakage dose to sum together. Leaf travel should be parallel to the minor axis of an elliptical lesion. So I'll give you 30 seconds to answer that.
All right, please click on the flashing icon to answer the poll question posted on the left-hand side of this window. Once you have submitted your answer, you will be able to see how other participants have responded. We'll give you about 30 seconds. Okay, thank you for answering the poll. Back to you, Austin.
Okay, so this is a tricky one because all the statements are true, but only one actually addresses the question. And I probably should have specified, I'm not sure if the MLC travels along a different, if it's orthogonal for non-variant machines. But rotating the gantry along the leaf travel path should be avoided because leakage dose can sum together. It's true that large leaf gaps from multiple lesions will increase normal tissue dose, but depending on their orientation, you'll have to play around with the collimator angle to find out what that optimum angle is, and that can vary from case to case. The previous two answers were B. And leaf travel should be parallel to the minor axis of the elliptical lesion to increase conformality as well. But again, that can be at any number of angles depending on the treatment itself. So SRS Linac QA is held to a tighter criteria than most normal QA. TG142 kind of introduced this concept of different criterion depending on the use of the machine itself and created a separate category for SRS and SBRT machines. Most of the differences are going to relate to patient position, so your isocenter, coincidence, position indicators, maybe your treatment couch rotation or collimator angles and things like that. And it's especially important, as I mentioned before, if you're treating multiple Mets, those you're kind of doubling down on some of those tolerances. And again, because we're delivering such high doses, you don't get a chance to take those back or to average them out over treatment, so we need to be especially careful. Maintaining a tight isocenter is especially critical to SRS. For us on treatment days, we always perform a Winston-Lutz test in the morning, which I included the citation from Winston Lutz. And I guess there's a third guy that wrote this paper, and somehow his name got left out of the Winston Lutz test, so kind of feel bad for him. You can deliver the Winston Lutz test either with an MLC-defined field or a cone field, and you can use either film or an EPID to capture that image to assess the results. The couch will remain fixed, and you'll take multiple gantry angles to test the gantry ISO, and the gantry can remain fixed, and you can take images at multiple couch angles to take the couch ISO. And here to the right is the cone mount that we use for our Winston-Lutz test. So what we'll do is we'll rotate the gantry either to 270 or 90 degrees, and we will drop that mount into the accessory slot. You want to keep your collimator either at 90 or 270 so that it's facing up, and allow gravity to kind of do its work for that mount to slide all the way to the bottom. Because even though it latches, there's still a little bit of play in that accessory slot, and we found that if we do it at a non-270 or 90, there's a chance that it may not settle all the way, and when we tighten those screws to the left and the right to hold that mount in place, it may not be perfectly at isocenter, and we'll see failures in our Winston-Lutz test itself. There it is with the 7.5 millimeter cone that we use. We'll just attach that to the mount. And then there's the Winston-Lutz phantom itself. And you can align that off of the crosshairs there. We typically use the light field to align that. There's a 4 millimeter sphere in there that will then show up within the 7.5 millimeter cone. You can use MLC instead of cone. If you have 2.5 millimeter leaves, then you can just retract 3 of those leaves to get your field. And here's the resultant images from those cone-based tests, and you can kind of qualitatively evaluate those or quantitatively measure the center of the lighter image, which is that phantom, with the darker, which is the aperture of the cone itself. It's easier to eyeball that for a cone-based treatment. You may need software to do the analysis for an MLC-based treatment. It's important, too, that you're measuring from the center of one to the center of the other. If you place your digital graticule and do that measurement, then you're introducing any potential uncertainty with the position of the MV panel itself. So as long as you're doing phantom relative to aperture, you should be okay, and you should be eliminating that as a source of uncertainty. Okay, so another review question. When performing the Winston-Lutz test, which of the following collimation techniques is inappropriate? Using cones to perform the test and cones to treat the patient, using cones to perform the test and MLC to treat the patient, using MLC to perform the test and MLC to treat the patient, or using MLC to perform the test and cones to treat the patient. think there's one option here in particular that should be avoided. Two that are certainly right, one that's maybe a little suboptimal, and one that should definitely not be done.
All right, so you can go ahead and click on the flashing icon to answer the poll question on the left-hand side of this window. Once you have submitted your answer, you will be able to see how other participants have responded. We will review the answer in about 30 seconds.
I see a couple of questions here in the chat regarding plan QA. I'll hit on that in a slide here in a minute. And for the Phantom that's used for the Winston-Lutz test, it's just the Winston-Lutz Phantom itself. We do the analysis and offline review in ARIA, which are those images that I showed.
All right, thank you for answering the poll. Back to you, Austin.
Okay, it looks like it was a pretty even split between B and D, and so I'm glad that we seem to agree by consensus that A and C are the best. I would say that what you should definitely avoid is using the MLC to perform the test and the cones to treat the patient. And the reason that is because you are failing to check that the actual cone placement itself, which would be manifested in the ISO center, if that placement isn't accurate, you would see a failure in your Winston-Lutz test, and I kind of alluded to that where we saw if it wasn't fully settled in the accessory slot, we were failing our Winston-Lutz test. And if you were to perform that Winston-Lutz test with the MLC and then treat with the cones, you might not catch some positional error there, which for some of these lesions could result in not hitting the lesion at all. In terms of using cones to perform the test and MLC to treat the patient, it may be suboptimal. I think what you're losing here is potential errors in MLC positioning or banks, but I think ultimately you're still testing the actual ISO centers themselves, and so I think it can be argued that it's okay but suboptimal itself. And as far as the software for analyzing the Winston-Lutz, we don't use software for evaluating our cone-based Winston-Lutz tests. For MLC, I think that's probably a good idea. I don't have any experience using those, any of those programs, so I encourage you to try reaching out to somebody else, or maybe somebody else can chime in if they have experience with that. So patient-specific QA, that's also an important part of SRS QA, much like it is just for IMRT QA. There's numerous options available for performing your QA. We use the Delta 4 system, which is 2 orthogonal diode arrays in the Phantom shown there to the right. Whatever you use, I think it's important that you're aware of your equipment and its limitations. Obviously, a very thorough commissioning of your use of this device. Be aware of detector spacing and size and how that may be impacted by some of the small fields that are used in SRS. Like I said, we treat a lot of our patients, or almost all of our patients, with ARCs, so make sure that you're comfortable with that device being able to handle the ARCs themselves, and be aware if there are dose rate dependencies to the detectors themselves. For our static field IMRT plans, we use portal dosimetry with it, which uses variance epidetector, but that cannot be used for flattening filter-free beams on the older 30 by 40 MV imagers on TrueBeams, because the detector itself will actually saturate at isocenter, which is where we typically measure those for IMRT QA. So Varian actually recommends that you take that down to 170 centimeters source to imager distance, I believe, to get rid of that saturation effect. The new 43 by 43 MV panels are capable of measuring doses at those FFF dose rates, but again, that's just an example of a dose rate dependency that you may run into. In terms of how we analyze it, we do fix the couch at 0 degrees, so we don't have to worry about any potential collisions, because that Phantom may be positioned slightly different than if we were to just have a head frame based on the end. And we'll do a field-by-field analysis, so we'll check each arc to make sure that we're within 3%, 3 millimeters, and a passing rate greater than 90% is what we use. The actual treatment day workflow. So this kind of ranges all the way from an initial timeout where you'll collect patient information before the patient goes into the room. We'll do a review to make sure all QA was performed, both the patient-specific QA as well as the morning QA that includes the Winston Bloods test, which is especially important. Proper assembly of the immobilization device itself on the couch. Then the patient is initially positioned by the therapist. We'll do 2D images first for initial positioning and shifts using either ExactTrack or OBI. We have two stereo machines. One has ExactTrack and the BrainLab couch. The other has a Varian 6-degree of freedom couch, and we'll just use OBI. Then we use cone beam CT for the final alignment. That's reviewed by both physics and an MD prior to beam on. If it is a frame-based patient, we'll then verify that the patient is in generally the correct position. Probably won't line up perfectly to the target positioner box, and I'll show you a picture of that here in a minute when I address that specifically, just to make sure that we're in the general area and that we haven't shifted too far when applying those 2D 2D or 3D 3D matches. Then we'll do the final timeout of the plan itself, followed by the actual delivery of the treatment. So for initial positioning for U-frame, we'll place this box over the frame. It fits much in the way that a localizer box does, and you can see it will have little crosshairs here that you can line up to. Looks like this particular case was 2 isocenters. So the TAPO box, or the target positioner box, is used for that initial alignment. Frameless patients can be set up just based on parts and the lasers. And either way, we'll take images after that to kind of get our initial position. So initial shifts of the patient are applied through 2D 2D match, as I mentioned, either ExactTrack or OBI images. The ExactTrack system is 2 X-ray tubes in the vault floor, capable of doing 6-degree freedom corrections with the BrainLab couch. One of the advantages of this is you can image at multiple couch angles and do those corrections, whereas you might be a little more concerned about collisions and the gantry rotating for different couch angles. OBI KV images are just orthogonal images taken with the OBI arms. Typically, it's just translational corrections. So if you have Varian's 2D 3D match tool, tool, that's a typo. You can also do 6-degree freedom corrections. I showed some of the BrainLab images down there at the bottom. And BrainLab works really well. The images are a little bit harder for me to interpret than just an AP lat image, so I kind of partial to OBI in that sense, but BrainLab is great for doing 6-degree corrections and multiple couch angles, and we've had a lot of good success with that. The actual final position of the patient is determined from cone beam CT. We use a skull to align with the DRR. Probably not going to see anything of the lesion in a cone beam CT. So you want to focus on a region near the lesion. Like I said earlier, especially important near the base. You can pass over contours on the DRR so that you know what area you're treating it, and you can be especially careful there. If there's any shift greater than 2 millimeters, we'll retake the cone beam CT. Shifts should be pretty small since we've already aligned based off the 2D imaging. We just use our cone beam CT as kind of our gold standard for applying those corrections and checking the final position. 6-degree of freedom, or 6-degree corrections, so all your 3 translational, your rotation, and your pitch and roll can be done at the console for the Varian 6-degree freedom couch or with the ExactTrack system. We'll have physics review the images, and the MD will sign off on those. And as I mentioned before, you can do a final position check against the TAPO just to make sure you haven't made any gross shifts that wouldn't make sense with where you're treating. The TAPO box probably isn't going to align exactly after you apply your shifts. Even the TAPO box itself can weigh down that frame a little bit and cause a bit of deflection. So after you correct for images, you might not see it line up as well. And I should mention, we take that TAPO box off for treatment. It's only there for the initial positioning, then it's taken off for all images and treatment. The timeout is performed before every beam or arc. We want to verify that the gantry angle, collimator, the couch positions are all correct. Shifts have been applied appropriately to the couch. We write down all of our shifts. We have a kind of a timeout sheet that we keep at the the console for all of our SRS patients that basically takes us through every step, and that's signed off on by a therapist or a physicist, just to ensure that we complete every single step, no matter how trivial it may seem. I think that's a really good procedure to try and avoid any potential errors. We'll check the initial MLC shape against plain images that are saved in the treatment document, just to make sure that looks okay there. Do a comparison to the MU, the beam energy being used, the dose rate. We'll check all those at the console, comparing it to the chart. And then, as I mentioned, we have that checklist to ensure that all steps are completed and they can be signed off. Then we'll keep that on file. So, review question. Which of the following are important components to an SRS timeout? Patient identification, position verification, so things like gantry, collimator, or couch. Checking the console MU against the chart. Verifying that appropriate daily and patient-specific QA has been completed. E, all of the above.
All right, this is our last poll question. Please go ahead and click on the flashing icon to answer the poll question on the left-hand side of this window. We'll take about 30 seconds to answer the questions. Okay, thank you for answering the poll. I'll turn it over to you, Austin.
Okay, good. The answer is all of the above. Those are all certainly important things to check. As I mentioned before, we're delivering a lot of dose in one fraction. So it's important that we be especially careful. And timeout is certainly an important step to good quality control. So I guess putting it all together now that we've kind of walked through this, I think it's important to not only review each component itself, but also the sum of the components. You can do this through a number of end-to-end phantoms. Steve, Lucy, stereo fan. IROC has phantoms for participation in clinical trials and auditing. I believe they may also have a phantom for fee service. I did my dissertation work at IROC, so I'm a little bit partial. I worked with this phantom quite a bit. You can evaluate the different options based on the need and the purpose and the things that you want to use them for. But I think it's a good idea to be able to check, putting some sort of anthropomorphic phantom into a mobilization, simming it, contouring it, planning it, delivering that plan, and making sure that it's all matching up with what you hope to get at the end of treatment. So some important things that weren't covered in this presentation, and things that should be looked into further as it pertains to SRS. I didn't touch at all on commissioning of an SRS machine or a model in the treatment planning system. Small field dosimetry is very tricky, and we could talk for hours probably on that. Lack of lateral electronic equilibrium. You need to have small enough detectors. Some of those detectors, depending on you're using, may have energy dependence. So just your choice of how to collect those measurements is important. Creating a comprehensive QA program and reviewing the entire kind of process map, so to speak, for SRS. We talked about some specific examples, but you want to take care to create a program that addresses all aspects of the treatment and is robust in addressing those things. So I guess key takeaways of SRS, kind of a closing note here. High doses are delivered in a single fraction, or less than or equal to 5 for SRT. Highly conformal dose distributions, steep dose gradients. We're looking to achieve an accuracy of plus or minus 1 millimeter, or ideally less. The workflow that we discussed in the previous slides, all in one way or another, comes down to addressing some of these points, specifically the accuracy itself. So I'm going to include my contact information here. As I mentioned, I'm in the last few months of my residency, so I know that these presentations are recorded, so if you're watching this in the future or just think of something in the future, make sure and look me up in the AAPM directory, as this information could change. I'd be happy to answer any questions to the best of my ability or offer any clarifications.
Thank you, Austin. It looks like we have a few questions, and we have a few minutes to cover those, if you don't mind.
Yeah, I'll try and look back through here. I kind of got behind on there. For the 3% 3 millimeter criterion for IMRTQA, yes, we still do use those for SRS plans, and that's maybe fair to question whether that's as appropriate given the accuracy that we're seeking to achieve. But I think it's important to keep in mind that those tolerances are not just based on what's acceptable for the plan, but also the setup that you're using. I view IMRTQA as basically a check of the delivered fluence against what you intend to deliver, and for gross errors. A lot of the errors, some of the trickier ones to deal with are related to positioning and patient positioning and things like that, and that's not necessarily captured in IMRTQA. But I still certainly think it's a valuable part of the QA program. I just think you need to understand what all it can catch and can't catch. As far as shooting each field separately for map check, I'm not as familiar. As I mentioned before, we shoot individually and analyze them field by field, but we also want to make sure that the sum of all those fields and the total dose is in good agreement. Cone beam CTs, so anytime it's SRS or SRT, we'll always do a cone beam CT. So even if it's 5 or 3 fractions, we will still do a cone beam CT before treating. If it's a primary brain treatment like a GBM or something, then we may not cone beam for every single one of those fractions. As far as if there's 3 arcs, do we cone beam 3 times or 1? So usually we'll only have 1 arc in the actual with a couch angle of 0. We may split that up into 2 arcs if I want to rotate the collimator halfway through to achieve, so that we avoid irradiating normal tissue for multiple mets. Like sometimes that can be tricky on a full arc. But you can't really do a cone beam CT if you have very much of a couch kick at all, because you have to worry about collisions, and that's one of the advantages to using exact track system. You can actually check that. But we just base it off of our cone beam that's acquired at a couch angle of 0. Physics is present for all fractions of SRT as well, whether that be 3 or 5 fractions. So that carries over from SRS as well. So the radiobiology of SRS versus hyperfractionation. So again, we're assuming that everything that we contour in that target is cancerous disease. Fractionated helps particularly when we have normal tissue that's mixed in, so an actual primary treatment. In that case, we are taking advantage of the fact that oftentimes the healthy tissue can repair better than the cancerous tissue. So we'll repeatedly deliver some amount of dose, allow the healthy tissue to repair, and then hopefully we can eventually take that cancerous tissue down to 0. In the case of treating a MET, which is what we're doing in SRS most of the time, we're just delivering a single ablative dose, and so we want to make sure to capture it all right then. The RTOG max dose fraction, that's RTOG 90-05, if you want to look up that actual study. So that's the recommendations on maximum tolerable doses. And as far as whether it's required, I mean, so these are ultimately physician decisions. Sometimes they'll use their best judgment to change those. Those are just some general guidelines from that particular trial, and often is what informs kind of that physician decision. And you can talk to your physician and get an idea of what they're comfortable with and what they're willing to do. If couch ISO is more than 1 millimeter, should it be considered in the PTV margin? So that goes back to where I was showing the expansion of your GTV to PTV is well, it's actually this slide here that I have pulled up, where that's increasingly adding normal tissue. So your decision on how much to expand, some people don't do any expansion at all. We do 1 millimeter. There's been cases where I've seen 2 millimeters if we were basing that off of a diagnostic CT image because the patient had a pacemaker that couldn't go through the MR. you know, if your ISO center is getting outside of that, you know, that would make me a little bit nervous for SRS. You know, whether you'd actually continue to treat with that. I mean, you know, certainly you can up your margin itself, but just be aware of the increased normal tissue dose that you're getting as a result. Which I think that looks like most of the questions. Again, feel free to email me. So, thank you all.
Thanks again, Austin, and thank you all for joining us for this free event hosted by WePast. For up-to-date information about future webinars, follow WePast on Facebook, Twitter, and Google+. Now, help us improve these webinars by taking this short survey.